Hello, everyone. Welcome to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Sabin, your host for today's episode, and today I'm joined by Ghena Abu Sharia as we'll dive into the world of breast disorders, exploring the powerful impact of early detection and everything about this vital topic.
Hi everyone, thank you Sabine for that lively introduction, and I hope our listeners are wearing pink today. Let's start.
All right, so why don't we kick things off with a quick anatomy refresher to get our brains warmed up? Then we'll plunge into the fascinating world of developmental disorders before diving even deeper into the depths of lesions and beyond. Breast anatomy is not just fat and ducts. There's a lot going on structurally and embryologically.
Exactly. So, structurally, the breast is a modified sweat gland. It's made up of lobules, which are the milk producing glands, ducts that carry milk toward the nipples, and the interlobular stroma, which is made up of fibrous and adipose tissue. All of this sits over the pectoralis major muscle.
You've summarized the anatomy very well, Rina. What about the mammography screening? What is it? What are its essentials? Give me all the details.
Mammography is a specialized imaging technique that uses low energy X rays to create detailed images of the breast tissue. It is primarily used for two main things: early detection of breast cancer, especially before it becomes palpable, and for diagnosing non palpable lesions or tracking suspicious findings. It's an important tool in asymptomatic women, used as a screening method after a certain age.
Oh, okay, so it's a screening tool. What are we exactly assessing in the breast?
So, Sabine, there are two major features we assess. First is density. Cancers typically appear as dense masses, which look like white areas. So, when you see a focal area of increased density, it raises suspicion. Next is calcifications, especially microcalcifications, that look like tiny white specks. These can be benign, but when they're irregular, clustered, or linear, they may indicate invasive carcinoma or ductal carcinoma in situ, which is known as DCIS, which are most commonly detected as mammographic calcifications.
Okay, so when should screening start?
Let me give you and our listeners some valuable advice. Mammography is recommended for ages 40 to 74, but in cases of family history, we start earlier. So, don't forget to remind your relatives to get screened as well. Early detection can make a crucial difference.
Thank you for the valuable advice, Rina. But just to be sure, not all calcifications are bad, but certain patterns throw up red flags, right?
Exactly. Coarse or scattered ones are often benign, but tight clusters or linear branching patterns are suspicious and warrant further evaluation.
Okay, everyone, I think we're ready to start with our first case. So we've got a 20-year-old woman who noticed a small lump in her axilla that seems to get more prominent during her period. It's soft, mobile, and not painful.
Yup, that's a classic presentation of one of the developmental anomalies of the breast. We need to look for accessory axillary breast tissue and congenital nipple inversion.
Okay, so what if a patient presents with inverted nipples? How do we know if it's normal or a red flag?
Okay, basically, if it's congenital, it's usually bilateral and present from birth, and this is totally benign. But if inversion happens later in life, especially if unilateral, that raises concern for something deeper, like an underlying malignancy causing retraction.
All right, quiz time. What's the key feature that helps you distinguish benign congenital nipple inversion from pathologic inversion?
Timing and symmetry. Congenital bilateral inversion that is present from birth is benign, but an acquired unilateral inversion is very concerning because it indicates presence of an invasive cancer until proven otherwise. Let's go to another case, shall we, Sabine?
Indeed, we shall. So we have a 28-year-old woman who recently gave birth, comes in with a swollen, red, and tender right breast. She's also running a fever.
This is acute mastitis. It occurs most commonly during early weeks of breastfeeding.
Kafu, you're correct. Tell us more about its pathophysiology.
Okay, so here's what's going on. It's caused by a bacterial infection, usually Staphylococcus aureus. The entry point is usually through cracks or fissures in the nipple. It presents with a hot, tender, erythematous breast and may be associated with fever.
All right, Next case is a 55-year-old woman who's not pregnant, presenting with a thick greenish discharge from her nipple. She described it as kiwi colored, and she also reports some tenderness and a pulling sensation.
Now, this is most likely ductectasia, a non-bacterial inflammatory condition.
You've got it! Can you tell us more about it?
Of course, ductectasia occurs when large ducts near the nipple become dilated and filled with granular debris and macrophages. Over time, this causes 1. Chronic inflammation, 2. Possibly periductal fibrosis, which leads to nipple retraction and a thick white or greenish discharge. And on histology, it shows dilated ducts with amorphous beers and foamy macrophages.
Okay, Ghena, are you ready for another case?
I never am, but go ahead, Sabine.
Okay. So we have a 50-year-old woman. She has a firm, irregular breast lump. She was in a car accident a few weeks ago and the lump developed shortly after.
Okay, that sounds like fat necrosis. And to this woman's advantage, it's a benign condition that can really look like carcinoma on imaging and physical exam.
But when does fat necrosis make an appearance, and what events lead to its unexpected arrival?
So, fat necrosis is typically caused by trauma or prior surgery. Basically, what happens is adipose tissue dies. It then gets replaced by lipid-laden macrophages, inflammation, and later fibrosis and even calcification. On exam or imaging, it may appear as a firm, irregular, possibly calcified mass, which is why it often gets biopsied. And on histology, we see necrotic fat cells, foamy macrophages, multinucleated giant cells, fibrosis, and dystrophic calcifications.
All right, let's take a quick practice question. Which inflammatory breast condition presents with periductal fibrosis, nipple retraction, and greenish discharge?
Answer: ductectasia.
Nice work, Ghena. Next, we're jumping into benign epithelial lesions, starting with fibrocystic disease and working our way through papillomas and gynecomastia. Are you ready for us to dive into another case?
I guess this time I am. Let's go.
Okay, so we have a 35-year-old woman. She comes in with vague bilateral breast pain and nodularity that gets worse before her period. On palpation, both breasts feel lumpy, but no discrete mass is found.
This is a fibrocystic change, the single most common benign breast disorder in premenopausal women. You hear me? Premenopausal.
Spot on, Ghena. Can you give us some more explanation of the diagnosis?
Okay, fibrocystic disease, and more recently referred to as non-proliferative disease, it refers to a spectrum of benign epithelial changes in the breast, often driven by cyclic hormonal stimulation. It's extremely common in women aged 20 to 55 years old, especially in reproductive years.
So, from its name, fibrocystic change, we for sure need to look for certain patterns of changes. Am I right?
You're absolutely right. They exhibit 3 patterns of morphological changes. First one is cyst formation and apocrine metaplasia. This is where you see benign cysts of varying sizes, lined by flattened to columnar epithelium exhibiting apocrine metaplasia. The apocrine cells are large, polygonal, with abundant eosinophilic cytoplasm, and the cyst contains semi-translucent fluid. These cysts may rupture, leading to localized inflammation. Second, there's fibrosis, which leads to the palpable breast firmness. And finally, there's adenosis, which is increased acini per lobule, and that can also occur during pregnancy. And we can further categorize fibrocystic disease into 3 main categories, based on morphology and cancer risk. 1, we call it non-proliferative changes if there's no increased cancer risk. 2, if there's slightly increased risk, around 1.5 to 2-fold, we call proliferative disease without atypia. And finally, it's called proliferative disease with atypia if there's moderately increased risk of around 4 to 5-folds.
Ghena, can you go over the proliferative diseases again, please?
Sure, just because you asked nicely. Let's start with proliferative disease without atypia. This is usually an incidental finding that is detected as densities on mammography.
Oh, okay, so it's rarely palpable. That's why it's usually an incidental finding. Do we have types of proliferative disease without atypia?
Yes, we have 5 main types: epithelial hyperplasia, sclerosing adenosis, complex sclerosing lesions or radial scar, papillomas, and gynecomastia.
All right, let's start with the first one, epithelial hyperplasia.
Okay, epithelial hyperplasia is where you see more than 2 epithelial cell layers, unlike the normal tissue which only has 2 layers of cells, epithelial and myoepithelial.
Oh, okay, so epithelial hyperplasia is when you have many epithelial cell layers. Now, what about the second type, sclerosing adenosis?
For the second type, sclerosing adenosis, as you said, has increased compressed acini and lobules. These acini are what give it the name adenosis. It also has diffuse microcalcifications, which may mimic carcinoma on mammography, and that's why it's sometimes mistaken for cancer. The third type of proliferative diseases without atypia is the radial scar, aka complex sclerosing lesion. This has central fibrosis surrounded by radiating and dilated glands. So the radial in the name is from the radiating glands, and the scar in the name is from the central fibrosis. Sounds logical, right? It looks malignant because it presents as an irregular mammographic density, but it isn't malignant.
All right. So far we talked about epithelial hyperplasia, sclerosing adenosis, and the complex sclerosing lesions, also known as radial scar. We still have two more types of proliferative diseases without atypia, papillomas and gynecomastia. If I recall correctly, I think the papilloma type has subtypes, correct?
Yes, you're so right. Papillomas are basically papillary tumors arising from duct epithelium, and we can either have a central papilloma or peripheral papillomatosis. Starting with central papilloma, that's where you'll see a solitary, large duct near the nipple and it presents with bloody nipple discharge. Peripheral papillomatosis, on the other hand, has multiple small minor ducts that are deeper within the ductal system. So they're farther from the nipple and they don't usually present with bloody discharge, so they're polar opposites.
Oh, so you might see a large papilloma close to the nipple or many small papillomas further down from the nipple. Now, the last type of this group of diseases is gynecomastia.
Gynecomastia is a benign lesion seen in males with an estrogen or androgen imbalance, either during puberty, cirrhosis, or old age. It presents as subareolar enlargement, and histologically, we see ductal epithelial hyperplasia, but no lobules since male breasts lack lobular structure.
Okay, check it out. I have a mnemonic that can help us remember them. Every happy cat runs past grass. The first letters of each term goes as E and H for epithelial hyperplasia, C for compressed acini that we saw in the sclerosing adenosis, R for radial scar, P for papilloma, and G for gynecomastia.
That's such a good one, Sabine. The second disease now is proliferative disease with atypia. This group differs from all of the previous ones because we can actually see atypia here. It has two main types, either atypical ductal hyperplasia, known as ADH, or atypical lobular hyperplasia, also known as ALH. Both types show cytologic and architectural abnormalities, hence the atypia, and are considered precancerous lesions with a 4 to 5 times increased risk of developing breast carcinoma.
Whoa, Ghena, that was a lot. But it's okay, we're building up. Now we can actually shift from the benign lesions to the malignant ones. Let's dive into the big stuff, carcinoma in situ and invasive breast cancers. This one's big on the exams, big in clinical practice, and big in patient impact. Now, why don't we switch it up this time? You give me a case, and I will give you its explanation.
You know what? That's such an amazing idea. Let's do it.
Oh, but wait, before we do that, let me tell you the difference between breast cancer and breast carcinoma. Breast cancer is a broad term that includes all breast tumors, while breast carcinoma specifically refers to malignant tumors originating from epithelial cells.
That makes so much sense because carcinoma is specifically epithelium, but cancer is a general term.
Exactly. Now, hit me with a case.
Okay, are you ready? So, we have a 63-year-old woman that comes in saying she noticed a lump in her right breast while showering. She's had some occasional pain, and she's also noticed a bit of discharge from her nipple.
Okay, this is a typical breast cancer presentation in clinical practice, but let's break it down. There are three classic features of breast cancer you need to keep in mind. Remember the mnemonic PPN. P for palpable mass, the other P for pain, and N for nipple discharge.
Okay, Sabine, can you talk more about each of these features?
Let's do it. So palpable mass is the most common presenting complaint. The mass is typically painless, hard, immobile, and it may have irregular borders. Then we have pain. While pain is less common, it can occur. If it's present without other signs, it's less specific, but when combined with a lump, it raises concern. And finally, nipple discharge, especially if it's bloody or serous and unilateral. This is particularly suspicious when not associated with lactation or trauma.
Okay, wait, so just to emphasize, a painless lump is the top red flag. But bloody discharge is another big clue, especially if it's spontaneous and one sided.
Exactly. Also, important to remember that sometimes skin changes, like dimpling or nipple retraction, may show up. But we'll get into those more when we talk about inflammatory and invasive carcinomas. Now, quiz time! What is the most common initial symptom that brings women with breast cancer to the clinic?
Wait, is the answer a painless palpable mass?
Spot on, Ghena! Alright, Ghena, why don't we go over the epidemiology, risk factors, subtypes, genetic links, and all of that stuff?
We will, but before that, let's do just one last case. A 58-year-old woman presents with a painless lump in her right breast. It's firm, immobile, and she says it's been there for a few months. She went in for a mammogram that showed a dense mass with spiculated margins and some microcalcifications. Biopsy confirms invasive ductal carcinoma.
I'm sensing some red flags right here. Firm lump, mammographic density, and calcifications. It's breast carcinoma, right?
You're absolutely correct. And as you mentioned before, breast carcinoma refers to malignant epithelial tumors of the breast. Breast carcinoma is the most common malignancy in women and, unfortunately, second leading cause of cancer death in women worldwide.
Now, I know that risk increases with age, especially after the age of 30, and about 12% of women will develop breast cancer during their lifetime. But what are the other risk factors?
So, risk factors include unopposed estrogen exposure, like early menarche, late menopause, or nulliparity, family history as well, especially if it's first degree relatives, and germline mutations in the following genes: BRCA1, BRCA2, TP53, and CHEK2. And some other risks include ionizing radiation, alcohol, obesity in postmenopausal women, and use of hormonal replacement therapy. Interestingly, obese women below the age of 40 have reduced risk of developing breast cancer as a result of anovulatory cycles and lower progesterone levels. Also, women who use estrogen blocking drugs and those who have had oophorectomies are also at a reduced risk.
Okay, now Rina, tell me, in terms of subtypes, how are these cancers grouped?
Now, they're classified into three main categories based on immunohistochemical markers. The first group includes the estrogen positive, HER2 negative tumors, which make up the majority of the cases. These estrogen positive are usually seen in older women, and they are very slow growing and have a good prognosis. They're associated with BRCA2 gene as well, and are related to the luminal A and B molecular subtypes.
Okay, so when we think of BRCA2, we should think of luminal subtypes and estrogen positive, HER2 negative. What about the second group?
The second group includes the HER2 positive tumors. These may or may not be estrogen positive, but they're the only group that is HER2 positive. They're less common than the previous one, and they tend to be more aggressive. They often have HER2 gene amplification and respond well to HER2 targeted therapy. This group is also related to TP53 genetic abnormality.
HER2 positive tumors are more aggressive and they may be related to TP53 abnormalities, but respond well to HER2 targeted therapy. Okay, and the last group is?
The last group is the triple negative tumors. These are estrogen, progesterone receptor, and HER2 negative. Again, they're less common than the estrogen positive group, but when we see them, it's usually in younger women and BRCA1 mutation carriers. They're aggressive with poor prognosis and unfortunately have limited targeted treatment options.
Rina, did you know that hereditary breast cancer makes up only about 10% of all cases and most commonly caused by BRCA1 and BRCA2 mutations?
Yup, they can also be associated with TP53 and CHEK2 mutations. BRCA1 is usually in the aggressive, triple negative, high grade, and basal like type, while BRCA2 tends to be estrogen positive. People with the BRCA1 mutation have a 55 to 65% risk of developing breast cancer by the age of 70. You hear me? Age of 70. While people with the BRCA2 mutation have 45% risk, so it's a bit less.
Okay, now that we got all those genes out of the way, let's classify things. What are the main forms of breast carcinoma?
Broadly speaking, we split them into carcinoma in situ, which is non-invasive and invasive carcinoma.
Let's talk about each one.
Of course, carcinoma in situ, the non-invasive one, can either be ductal carcinoma in situ, DCIS, or it can be lobular carcinoma in situ, LCIS. But then, the invasive carcinoma has many, many types. 1. Invasive ductal carcinoma. 2. Invasive lobular carcinoma. 3. Medullary carcinoma. 4. Mucinous colloid carcinoma. And 5. Tubular carcinoma.
Interesting. Ghena, if you don't mind, can you tell us more about ductal carcinoma in situ?
Okay. Ductal carcinoma in situ is a neoplastic proliferation of epithelial cells confined within ductal spaces, but remember, without invasion. That's why it's called in situ. It's E-cadherin positive and usually multifocal and bilateral. Most cases are detected by mammography due to microcalcifications. DCIS is treated by mastectomy with wide local excision and unfortunately has risk of recurrence.
Okay. So, if I'm not mistaken, we can further classify ductal carcinoma in situ into types, right?
Yes, it can be classified into 1. Comedotype, which shows ducts lined by malignant epithelium and central necrosis with calcified debris. This type has the worst prognosis, and the risk of invasion is 100% if left untreated. We also have the cribiform type. Cribi means punctuated, so we'll see round, regular cookie cutter spaces with calcified secretory material inside the lumen. This type, however, has a 30% risk of invasion if left untreated. Some other types include papillary type, micropapillary type, and solid type.
Okay. There's a special condition that might be related to ductal carcinoma in situ. So let's do a quick case. We have a 6-year-old woman who comes in with an itchy, scaly rash on the nipple that looks like eczema. She's tried steroid creams, but it hasn't gone away.
Oh, is this Paget disease of the nipple? That's a form of carcinoma in situ that involves the skin of the nipple and is almost always associated with underlying DCIS or invasive carcinoma. Paget disease is characterized by Paget cells, which are malignant glandular epithelial cells within the epidermis of the nipple and areola. These cells are large with pale cytoplasm, prominent nuclei, and they may appear singly or in small clusters within the squamous epithelium.
Yup. But how do patients present, Ghena?
Okay, clinically, patients present with the following: an erythematous crusty or scaly nipple and surrounding areola. Itchiness is also a very common feature that's often mistaken for eczema. And in many cases, there's a palpable mass indicating an underlying invasive carcinoma.
So when you see these skin changes, you don't just treat the skin, you investigate deeply. Okay. So all of that was ductal carcinoma in situ. Now what about lobular carcinoma in situ?
Lobular carcinoma in situ is a clonal proliferation in the lobules, always incidentally found, and there are no calcifications or masses on mammograms. Usually, the lesions are multifocal and bilateral and histologically show monomorphic cells inside the lobules. Unlike the ductal one, E-cadherin is negative here in the lobular one. The lobular carcinoma in situ also does not form a palpable mass. If left untreated, it has a 30% risk of becoming invasive breast cancer in 20 years.
Wow, Ghena, that covers carcinoma in situ pretty well. Now, let's discuss invasive carcinomas. We previously mentioned the types, which are 1. Invasive ductal carcinoma, 2. Invasive lobular carcinoma, 3. Medullary carcinoma, 4. Mucinous colloid carcinoma, and finally, tubular carcinoma.
Okay, invasive carcinoma in general typically presents with a palpable mass and calcifications on mammography without density changes. They could appear red and involve dermal lymphatics in the case of inflammatory carcinomas, or show skin dimpling in the case of larger carcinomas. For tumors at the central portion of the breast, they show nipple retraction.
Okay, how about you give us more details on each type?
Of course, let's start with invasive ductal carcinoma, IDC. It's the most common invasive carcinoma. I will break down the process for you and for our listeners. So, first, there's a fibroblastic stromal reaction to tumor cells, leading to a palpable mass with a hard consistency. Now, this may cause skin dimpling or nipple retraction due to infiltrative attachment to the surrounding structure. Its gross morphology shows chalky white stroma with irregular borders and occasionally calcifications. And on histology, we see dense stroma with large epithelial cells that either have a glandular, cord, or sheath arrangement. Invasive ductal carcinoma ranges from a very well differentiated glandular formation to poorly differentiated solid sheets of pleomorphic neoplastic cells.
Okay, so quick recap. So, invasive ductal carcinoma, which is the most common invasive breast cancer, presents as a hard, irregular mass due to stromal reaction and infiltration. It has a chalky white appearance, and histology shows dense stroma and variable epithelial patterns, from well formed glands to pleomorphic solid sheets. Oh, that was a lot. Next is invasive lobular carcinoma.
Okay, so focus with me. Invasive lobular carcinoma, ILC, is the second most common invasive cancer. It's often bilateral and multicentric. Its gross morphology shows a firm, hard mass with irregular borders, and histology findings show Indian file arrangement of cells and desmoplasia. There's also loss of E cadherin, like lobular carcinoma in situ.
Now keep in mind, the Indian file pattern is a very important distinguishing feature, where we'll see an invasion of one single line of malignant cells and no duct formation.
Exactly. Next is medullary carcinoma, which is a well circumscribed mass and one of the rarer types, described as triple negative, meaning estrogen receptor, progesterone receptor, and HER2 gene mutations are all negative. In histology, we see sheets of malignant cells with scant fibrous stroma, as well as lymphocytes and plasma cells around the tumor. We can also see necrosis and hemorrhage. Also, there is no desmoplastic reaction going on here, which is why it presents as a soft and fleshy mass.
Soft, well circumscribed, triple negative gene mutations, and no desmoplastic reactions. Got it. What about the next type of invasive carcinoma? The mucinous carcinoma.
So, mucinous colloid carcinoma is a sharply circumscribed, slow growing tumor seen in older women. It produces abundant extracellular mucin, hence the name. Grossly, it has a soft gelatinous appearance and glistening cut surface. In histology, we see tumor cells floating in mucin lakes.
So now we have one more type of invasive breast carcinoma left.
And that's tubular carcinoma. This is a well differentiated grade 1 cancer that typically presents without a palpable mass and is detected as irregular densities on mammography. And thankfully, it has a very good prognosis. So that was a very happy ending.
Oh my god, that was a deep dive. Let's give Ghena a break and do a practice question. Okay, listeners, listen up. A 45-year-old woman is diagnosed with breast cancer. On histology, the tumor shows sheets of large anaplastic cells surrounded by a dense lymphoplasmacytic infiltrate and pushing borders. There is no expression of the estrogen receptor, progesterone receptor, or HER2. Now, what is the most likely tumor subtype? A. Invasive lobular carcinoma. B. Medullary carcinoma. C. Mucinous or colloid carcinoma. D. Tubular carcinoma. And E. Invasive ductal carcinoma.
The answer is B. Medullary carcinoma.
Perfect. Now here are the key clues. 1. There were sheets of large anaplastic cells. 2. There was a lymphoplasmacytic infiltrate. 3. Pushing borders. And 4. It had a triple negative profile. These features are all classic for medullary carcinoma, especially in BRCA1 mutation carriers. Alright, let's talk about survival and outcomes. What affects prognosis?
For prognostic factors, we split them into minor and major, and a great way to think of them is by dividing them into major factors, where the cancer is and how far it's gone, and minor factors, what kind of cancer it is and how it behaves biologically.
Okay, Ghena, so let's start with the major prognostic factors.
Okay, the major prognostic factors are where we assess the following. 1. Invasion versus in situ. 2. Extent of lymph node involvement. 3. Distant metastasis. Always remember that hematogenous spread is a sign of poor prognosis. 4. We also look at tumor size. When it's less than 2 centimeters, it has a better prognosis. And 5. We assess locally advanced disease. 6. Inflammatory carcinoma. And finally, lymph vascular invasion.
Okay, so tumor size, any invasion, and lymph node involvement. Got it. Now what about the minor factors?
So for the minor factors, they include 1. Histological subtype, in which infiltrating carcinomas have the worst prognosis. while tubular and cribiform show the best prognosis. And then we have the tumor grade, which is assessed using the Bloom-Richardson grading method that's based on amount of well-formed tubules, nuclear pleomorphism, and mitotic rate. We also look at estrogen-progesterone receptors, the hormone-positive cancers. For example, estrogen receptor, progesterone receptor positive have much better prognosis because they respond better to therapy. If they are estrogen receptor and progesterone receptor negative, then they respond less to hormonal therapy but better to chemotherapy. We also assess the HER2 neoexpression. If there's an overexpression of HER2 neoreceptors, then it has poorer prognosis but responds well to hormonal therapy or chemotherapy. And finally, we have the proliferation rate, which can be assessed by Ki-67 immunohistochemistry staining.
All right, quiz time. So what tumor size indicates a better prognosis?
And the correct answer is less than 2 centimeters.
Okay, I think we've had enough of these invasive carcinomas. So let's shift the talk a bit. Picture this. A 22-year-old woman presents to the clinic with a firm, mobile lump in her right breast that she noticed while showering. It's not painful, and she's worried it might be cancer. Ultrasound shows a well-circumscribed, homogeneous mass.
Now, Sabine, this is most likely a fibroadenoma, the most common benign tumor of the breast in young women.
Kafu, Ghena. Now tell us more about fibroadenoma.
Fibroadenoma is a benign stromal tumor composed of both a fibrostroma and a glandular epithelium, hence the name fibroadenoma. It arises from the terminal duct lobular unit. These are super common in women between 20 to 35 years old. They're usually solitary, mobile, and non-tender. Because the mass is mobile, we sometimes call it breast mouse. Also, they typically increase in size during pregnancy and regress in size after menopause. Grossly, they appear as spherical, well-circumscribed, encapsulated nodules with a pearly white surface. Microscopically, you'll see compressed ducts surrounded by a proliferating stroma.
Okay, so for treatment, do we perform a lumpectomy?
You're absolutely right. I think we can move on to a new case now. What do you think?
I agree. So we have a 45-year-old woman with a rapidly enlarging breast mass. It's firm with irregular borders. Biopsy showed increased stromal cellularity and mitotic figures.
That kind of raises a flag for a phyllodes tumor, which is also a stromal tumor but much more aggressive.
Great job, Ghena. Now, can you give us more insight into this tumor type?
Sure. So phyllodes tumor, like fibroadenoma, arises from intralobular stroma. They are uncommon fibroepithelial tumors that occur at any age, but mostly in older women, especially in the 6th decade. They can be benign, borderline, or frankly malignant. They have a characteristic leaf-like architecture due to cleft-like spaces lined by epithelium and overgrowing stroma.
Fun fact, phyllodes actually means leaf. That's why we see this leaf-like architecture in phyllodes tumors.
Wow, that actually connects it really nicely. These tumors don't typically metastasize when they're low-grade, but they have a very high recurrence rate. And if they are high-grade, they typically spread hematogenously. Now, surgical excision with wide margins is essential, even for benign types, to prevent recurrence. Malignant phyllodes tumors can metastasize, so clear margins really do matter here.
Okay, now let me also add that in histology, we'll see finger-like projections that will help us differentiate it from fibroadenoma, where we would see fibrous and epithelial tissue. Okay, big picture now. Someone walks into the clinic with a breast lump. Where do we start?
Okay, our last segment is giving pro vibes, Sabine.
Oh no. So would we start with history?
Yup, exactly. We start with history. We'd ask about age, menstrual and reproductive history, family history of breast cancer, onset, duration, and changes with cycle, pain, discharge, systemic symptoms, all of that fun stuff.
Oh, and don't forget to ask about their diet and if they take any medications.
Yup, that can be important if we're thinking of estrogen. When we ask all these questions, we're specifically looking for the risk factors. The well-established ones include 1. Age, 2. Personal or family history of breast cancer, 3. BRCA mutations, and 4. Prolonged estrogen exposure, like from early menarche, especially before the age of 12, late menopause, or hormone replacement therapy.
And some other risk factors include high BMI, increased density on mammography, and nulliparity.
Now, after our thorough history, we do a clinical breast exam. Palpate in all the quadrants and the tail of Spence. And if you find a mass, check for the following: mobility, consistency, and the overlying skin. And also look for axillary or supraclavicular lymphadenopathy.
Now, after physical exam, we follow up with imaging. If the patient is less than 40 years or has a dense breast tissue, ultrasound is preferred. If she's more than 40 years old or you see any suspicious findings, then you perform a diagnostic mammography. Did you know in mammography we use the BI-RADS classification?
Yes, we do. Mammography uses the BI-RADS classification, and it means the following: 0 needs additional evaluation, 1 means it's normal, 2 means it's benign, 3 is probably benign, but you need to do a short interval follow-up, and 4 is suspicious and you should consider biopsy in this case. 5 is highly suggestive of malignancy, and 6 is a biopsy-proven malignancy, so go straight to biopsy.
And finally, the last step is tissue sampling.
Now, a core needle biopsy is the most reliable because it gives you the architecture. A fine needle aspiration shows you only the cytology, so it's less accurate and usually done only with cysts and not with masses. Now, based on the results, we classify the lesion as either benign, atypical, or malignant, and we proceed accordingly.
We are almost done. This episode has been a whirlwind tour through everything breast pathology. Let's do a final recap.
Okay, first, we spoke about developmental anomalies of the breast, where we need to look for accessory axillary breast tissue and congenital nipple inversion.
Then we went over inflammatory lesions. Acute mastitis is mostly seen in lactating women, usually due to Staph aureus. Then, duct ectasia is seen in postmenopausal women, where they present with green-brown discharge. Lastly, fat necrosis is due to trauma, and it may mimic cancer.
And after that, we discussed benign epithelial lesions. Fibrocystic change is common in premenopausal women, and non-proliferative versus proliferative, with or without atypia. And here, Sabin gave us a wonderful mnemonic: every happy cat runs past grass. For epithelial hyperplasia, compressed acini, radial scar, papilloma, and gynecomastia. The first letter of each term helps you remember each entity under proliferative disease without atypia. Don't forget that papillomas may involve a large central duct or a bunch of small peripheral ducts.
And now for breast carcinoma, aka the most common cancer in women. Its subtypes are luminal AB, which are estrogen positive, as well as the HER2 positive and the triple negative types. We can divide them into carcinoma in situ and invasive carcinoma. Starting with carcinoma in situ, it will include DCIS with calcifications and LCIS, which are often incidental. And for invasive carcinoma, it would include IDC, the most common type, ILC with the Indian file pattern, and finally, the medullary, colloid, and tubular types.
As for the prognostic factors, we have major factors and minor ones. Major factors, they include lymph node involvement, tumor size, invasion, and distant metastasis. And while minor factors include the exact subtype, grade, hormone receptors, and the mutations.
Finally, we talked about stromal tumors, which include fibroadenoma and phyllodes tumors. Fibroadenoma is seen in young women and it is mobile and benign. While phyllodes tumors is seen in older women, it has a characteristic leaf-like pattern and it may be malignant.
And last but not least is how to approach a breast lump, aka pro department. First, we take history, then physical examination, and then we do imaging, then biopsy, and we mention the core needle biopsy. Don't forget that, as it's the most reliable one. And finally is the diagnosis.
Phew, that's it for today's episode. Thank you for joining me, Ghena. This really helped me tie all those complex breast pathology topics together.
And thanks for having me. I really enjoyed discussing it with you.
And thank you all for tuning in to PodBites. Don't forget to spread breast cancer awareness by early detection. Until next time. Wow, you're very smart, Ghena.
La 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 la. Lobular carcinoma in situ is a clonal proliferation in the... What's happening? Proliferation. Or atypical lobular hyperplasia, known as ALH. I said that weird.